36-year-old patient of mine who has a cardiac ejection fraction of 11%. Now, in most settings, that's going to be a no-fly zone for any kind of surgery, period. So we're going to do this surgery, and you can see he's got a grade 2 spondy, six-step, you see he has pacer pads on, just in case the heart stops, and he did fine with the surgery, right? You can do surgery on people of literally limitless size. Size is no longer the issue here. You may not be able to do the weight component, but when you do these surgeries, it doesn't matter how fat the people are. In America, we have a lot of fat people. This is an example. This is someone with a BMI of 53, a 425-pound patient that we're operating on in the lateral position. You can see that. And indirect decompression. So this shows how, for example, here's a case. A lot of people do a 5-level fusion on this. We're going to do a 1-level fusion at the spondy level. You can see the ligament there. 6 months later, resolved. This is from distraction, indirect decompression, immobilization, and you can see the pre and post-op axial MRIs as well. So why do this? And I can go into this. This is data that I published in neurosurgery. It's very hard to get cost data in the U.S. And this shows, this is the ERAS spinal fusion, the awake fusion on the left, MIS TLIFs on the right. This is Mike Wang against Mike Wang. And you can see that the cost of the surgery goes down from $22,000 to $19,000. Now, that sounds expensive if you're not from America. That is incredibly cheap. Most people doing a TLIF in America, they cost $30,000, $40,000, even $50,000 to get the job done. You know, in our city, maybe it's a little cheaper in LA, but this is incredibly profitable the way we do it. And this is all published. Now, people are like, well, I don't care about that. I don't care about the fact that I'm going to be able to save money for the hospital. This shows data on 2 procedures of mine, randomly selected, of an MIS TLIF on the left and the awake TLIF on the right. And I don't want to spend too much time, I only have 10 minutes. But what you can see here is that I get in the room at the same time on both cases, 7:25, and then the prep start is 7:32 versus 7:49. Procedure start at 8 o'clock versus 7:38. Why? Because the patient flips themselves over. There's no bogey hookup. There's no bipolar. There's no light handles. There's none of that stuff. We are starting the surgery. They're 22 minutes ahead of myself. The procedure finishes at 10:56 here. 8:30 here. Guess what? You got to wake the person up. 10-minute wake-up's fast in Miami. Here, they roll right out of the room. So on the first procedure, I save 151 minutes of my own time. So I'll frequently finish my first awake TLIF before anybody in the hospital in Miami has cut skin. So this is truly efficient. I can do probably 8-10 of these a day and finish in a matter of certainly before 5 o'clock. Now here's the cost of surgery. I've been showing this slide a long time. I've been showing this since 2002. This is a slide I started at USC about the cost of surgery, the economic, social, physiologic, societal cost of surgery. And people talk about, well, what does that really mean, right? So then I started talking about the cost of surgery like this, about bending the cost curve down to background noise, which is where we were trying to go. And this is a slide I was using 10 years ago in 2012, saying if I could bend that cost of surgery down low enough, people wouldn't be so afraid of surgery, right? And then let me show you the new slide. So this is a company that me and some of my fellows started. This is activity-based analysis. This is very basic primary data. We are doing quaternary level data. It's a company now of analysis of motion in humans. We call it surgical phenotyping, surgical recovery phenotyping. Here you can see 2 patients, one in blue and one in red. The red is an endoscopic fusion. The blue is a microdiscectomy. What this means is that the recovery process, the granular recovery, I'm talking minutes, hours, not like your ODI at 2 weeks. The minute-to-minute recovery of a fusion is looking something like a microdiscectomy. This is a very scary slide because if you're a criminal, it's very easy to take this and say, well, we're just going to fuse it. But if you're thinking the way I'm thinking, you're saying, well, wait a minute, we can make a fusion surgery not such a horrible thing for patients. That is a huge difference, and that's what this whole course is about, how to do MIS surgery, right? And so this is Everett Rogers from Stanford talking about this sort of idea of the adoption curve and how things happen. And people have talked about this, and these slides are so mundane now, talking about how new technology arrives and some gets adopted. This is what actually happens. This is actual technology adoption, things like refrigerators that order food for you, stuff like that. And it's very haphazard, that there's a lot of factors that are affecting the adoption of surgery and why this happens. And so lots of lessons learned, right? I've learned a lot about how to deal with things like people who vomit, that are going to have a problem with awake fusion, how to clean the endoscopic equipment, how to do like end plate prep, and all this, and how to treat higher grade spondy. So let me show you a couple of complications. This is an example of a complication. This is a patient who is going to have a surgery below this level, and you can see that basically we're not going to be able to get into this area, right? So the facet size is too much. So getting access on this border is too dangerous for the dorsal root ganglion. Okay, so that's an example of how it can be a problem. Here's the key: targeting and access. If you haven't learned this yet, NASS has a whole course on pain. They had an injection course yesterday, the endoscopic course next door. We're going to do some of it here today on how you target the Camden's triangle, truly get into these spaces without stimulating the dorsal ganglion. The only structure really at risk is the DRG. So this is very different from other surgeries. There's no risk of CSF. Again, getting around that dorsal root ganglion and getting into the cage in proper position. Now this is a warning message as well, because I know people are like, well, I'm just going to try this. And this is from a book I edited on lateral surgery. It's the only actually textbook on lateral surgery besides the XLIF book, which is the company book. And this is from Luis Pimenta. Luis Pimenta actually tried to do XLIF in the prone position first and discovered that the only corridor you cannot get through is this corridor, right? So if you get lateral enough on the body, that is the only corridor you cannot get the spine safely through after you get past a certain upper side because of the dorsal ganglion. And so this kind of shows what it looks like. These are some slides of a patient that we actually took the superior articular process off of. You can spend some time with the endoscope to drill that. It does take a little time to do that, and then get the cages in the proper position, right? This is a case of a non-union. We've had 2 cases out of 400 with non-union. We'll probably have a couple more, but we've been running this project for over 10 years now, so we track our patients very carefully. Here's a patient. You can see this is a spinology. You can see there's some dissolution of the allograft, and here we resolve that problem by using the lateral approach. Lateral, XLIF, DLIF, OLIF, I don't know what you call it here in Thailand, getting in to put a cage in to solve that problem for you, and getting a result like this. So that happened about a year and a half after the surgery, right? So end plate preparation, very important to prevent non-union. We have a very low non-union rate. Right now it's under 1%. I suspect it's going to be about 1.3 or 1.4% the way I'm tracking the data. We're about to publish our data on our first 400 cases, just to give you some idea. You can actually clean and see end plate, the prepared end plate there bleeding. So where are we headed with this? It's not just to do these simple surgeries. We're trying to attack the very big bad problems like deformity surgeries and things of that sort. And this is what some people would call, Jeff Wong calls a Hollywood curve, and basically doing this with an awake fusion, 3-level, 130 by blood loss, and then taking this to the robot. And I expect for the other people that won't go over, but doing robotic surgery, you can adopt the robot to do the hard parts like the targeting, and all the other parts become automated. Now you can see how the surgery becomes something very simple and stereotyped and simplistic in some ways by using the robot to engage and achieve those effects. Getting lordosis, we'll talk about this later. ALL section to get greater lordosis from one and multiple collectulas. And I'll leave you with this thought. So here's that deformity I showed you, right? People are terrified of spine surgery. All your patients are terrified. My kids, all 3 of them had braces, right? Nobody's terrified of braces. And the reason is because they change how they take care of the body. So they don't come to me and say, Dr. Wang, for your daughter, what we're going to do, for your 16-year-old daughter, we're going to take a chisel, knock all her 32 teeth out, and implant 32 perfect teeth, and she's going to look great. You would never sign up for that, but that's what we tell our patients. So think instead about how they do this. Think instead about how we can modularly change the body, how we can take this process, and let's say that we were able to do all the deformity surgeries endoscopically, right? Release the ALL, do all this stuff we talked about, we published on this. What if we could do this without general anesthesia? What if we could do it over a set of surgeries, each one being very, very tiny, and then over 6 months, take a 92-year-old lady who's got a long life expectancy, do 3 surgeries 6 months apart, each one of them so tiny, it's like nothing to her, and then fix a deformity. That's really the goal, modularizing our surgery. This is what we believe in Miami the future is going to be, because my average age of patient is 73 years old. That's the average. So it's regular that I operate on a 96, 97-year-old because their parents lived to 105, right? So this is what's going on in Miami. Remember this is one of my favorite quotes. George Bernard Shaw said, "The reasonable man adapts himself to the world. The unreasonable one persists to adapt the world to him. Therefore, all progress rests on the unreasonable human being," right? So that sort of speaks to what we are responsible for. So again, thank you for coming out to Thailand for this course. Patrick and Jeff, thank you for involving me. John and Dr. Reitman, thank you for letting me give this talk to this audience. Okay.
Well, thank you, Mike. My name is John Liu. I'm a neurosurgeon from the United States. So what I'm going to talk about today is really kind of not necessarily to attack endoscopic, but I think if you had the opportunity to learn an MIS technique, which one would you rather spend your time learning? Just kind of a show of hands in here. How many people are currently practicing minimally invasive spine surgery? Show of hands. How many people are doing endoscopic approach? Only a couple. How about tubular approaches? So a couple. So most of us, I think there's a few that's doing MIS. So I guess the question is, if you were to make a decision to start doing the minimally invasive technique, which one would you rather spend time to learn? So I'm gonna make the argument that it's probably better to go with the tubular access. So this is my disclosure with nothing that pertains to this lecture. So the evolution of MIS in the United States has primarily been more through a tubular approach. These kind of sequential dilation through the muscles, and you're working through a small tube of different sizes. Could be either fixed, or it could be more of a modular type of tube system. MIS in the developed in terms of endoscopic, primarily outside the United States. So Mike is really one of the few people that's in the United States that's actually doing a significant amount of endoscopic approaches. So most of us in the United States are doing more of a tubular access. So I would make the argument that if you are to learn MIS approaches, tubular is kind of like what you're doing now, right? So in terms of we're not changing the operation, you're not learning a new skill set. So you're really learning to take care of patients through a small tubular access. It's faster to pick up. The overall optics are great in terms of being able to see things. The benefits are well documented, and I would make the argument is that the tubular approach is more versatile for you in terms of doing different things compared to endoscopic approaches. Now with endoscopic approaches, it's a different skill set. It's a steep learning curve. That with the stuff that Mike showed, these are not simple operations. So to get to his level, you're talking about years of experience, right? So the question is, we're one to spend the next 10 years trying to get as good as what Mike is doing. He's an outstanding surgeon. So it's really, it's tough for the average person that's trying to learn endoscopy today. It's a difficult operation. There's challenging in terms of visualization. It is a small incision when they first started. Now they're talking about more incision, more portals. They're a bigger incision now for more of the translaminar approaches. So these incisional sizes, they're really starting to become very, very similar between the tubular and the endoscopic approach. So is it truly better than tubular approaches? I think there's a lot of, I would make the argument that there's a lot more endoscopic literature out there, but it's really not showing that it's any better than the tubular approach. So in terms of application for tubular, start out with disectomies and decompressions. You can take the same operation and start doing T-lifts and fusion operations. The lateral access is based on a tubular access. And I can show you that you can also do extraforaminal approaches for disectomies and decompressions. And we'll show a little bit in terms of intradural tumor using all the same techniques that you learned with just one in terms of operation that you're going to learn. So this is the classic example of somebody who has a very tight stenosis with a spondylolisthesis, where you do what we call over-the-top decompression from the unilateral approach, and you can really achieve very good decompressions from a unilateral, just a MIS, a single incision, outpatient operations. You can look with that operation that you can actually carry that on and do intradural tumors through the same approaches. So we're not changing the operation, we're actually doing the exact same operation. Through a tube, you can actually take out this intradural tumor through a small incision, and these are very, very, so again, you're not learning a new operation. The operation you did for that over-the-top decompression is what we use to allow you to do that operation as well. And I will argue that you can't do that with an endoscopic approach. So this is kind of a classic pre- and post-op MIS tubular decompression of the lumbar sternoma. And you can close the dura. There's special bayoneted instruments that you can use. The actual closure of the dura is actually not that hard. You just need a specialized instrumentation. And you can do extraframinal approaches, this is just us taking the extraframinal disc out, or you can do a decompression, you actually see that nerve coming out. Again, outpatient procedures for these framinal disc or framinal decompressions. So the TLIF, it's again the same operations, right? You're not changing the operation, you're not changing the concept, you're still working through that tube to do these MIS TLIFs. Again, not making a new operation for you, just you're still using what you know for the open operations. And in terms of literature, this is the classic kind of MIS TLIF in terms of incision. It seems like every single day they add a different incision for this kind of TLIFs. There's a lot of literature out there, and really shows no clear benefit in terms of MIS versus tubular TLIFs at this point. This is a classic, this is a standard TLIF for a tubular approach. In my opinion, these tend to look better with just too small incisions. I'll kind of finish up with this case that actually a nice young lady that took care of her 43-year-old lady, cried, all 5 minutes confusion. 3 months she has supposed to left endoscopic discectomy after a spine surgery in the San area. And this is what she had, right? So basically a CSF leak from an endoscopic approach. As you can see on the monogram, it's an active leak, and she's very symptomatic from this. The question is now, how do you fix this? You can't really do it through an endoscopic approach. So this lady, we actually use a tubular approach to fix the endoscopic complication. And so again, it's kind of showing that versatility of a tubular approaches. You can just do a lot more from a tubular approach than you can. So I think in conclusion, tubular approach is more I think overall more versatile. It's the same operation that you're doing, we're just changing the charges. You get great optics, great visualization of the anatomy. And the endoscopic approach is a different operation. This is what you typically see with the endoscopic approach. So the question is, if you want to do this, and I borrowed this from Mike in terms of his endoscopic approach visualization. So these are just kind of different operations. And again, for me, if I have to spend time to learn MIS, I would pick the tubular approaches to learn. Very good, thank you.